Good morning, this is Dr. Sohrab Gollogly in Monterey, California. I'm a founding member of the Endospine Academy, which is headquartered at the Bulbous University Hospital in Zurich, Switzerland, a member of the International Spine Endoscopic Research Foundation, and a consultant for Arthrex's endoscopic spine team. One of the most frequently asked questions I get asked when teaching endoscopic spine surgery is whether or not a particular case is suitable for an endoscopic technique. So I'd like to walk through a couple of basic measurements on the preoperative MRI scan that will help you make that determination. First, we'll start with the interlaminar approach. Here we have an L5-S1 disc herniation on the right side at the L5-S1 level. I'd like you to observe that the spinous process is bulbous in its most dorsal aspect. That's the reason why we start the incision 5 millimeters off the midline. I'd like you to also observe that the medial border of the facet complex at the L5-S1 level creates a channel between those two areas, which is bridged by the ligamentum flavum. Measuring the ligamentum flavum on a number of MRI scans has taught me that the ligamentum flavum is typically about 3 to 4 millimeters thick, and that's the primary structure that you need to navigate through in order to arrive inside the spinal canal. The measurement that I find most effective is to measure the facet to facet width in the mid portion of the spinal canal at the level of intended resection, and make sure that that is medial to the ligamentum flavum, because when you insert the cannula via this approach, you will be skiving along the very medial border of the facet complex after releasing the ligamentum flavum from the bone. In this particular instance, this facet to facet distance measures 26 millimeters. We want that number to be greater than 20 millimeters, and the reason why is because you're going to insert a 7 millimeter cannula, here shown to size, and it needs to be able to fit in that gap between the spinous process and the medial aspect of the facet complex. And then there needs to be sufficient mobility in order to push the cannula away from you to visualize the edge of the S1 nerve root, and then sufficient mobility to rotate the cannula and pull the hand back towards you in order to displace the nerve root up over the top of the disc herniation. Experience has taught me that 20 millimeters is a borderline situation in which some bone may be required depending upon the local morphologic features of the spinal canal, but anything greater than 20 millimeters, and certainly anything in excess of 24 to 26 millimeters, there will be plenty of space for you to navigate your way into the spinal canal and resect this disc herniation without requiring any bony work during the approach. In terms of the transforaminal approach, here we have an L4-5 disc herniation on the right side that would be a good candidate for a transforaminal approach. If we go to the parasagittal view on the side of the herniation, frequently the dimensions of the foramen there are distorted by the fact that the herniation is present inside the foramen. Oftentimes there's surrounding vascular engorgement and inflammation, which distorts the normal anatomic landmarks. So what I like to do in this situation is go to the opposite foramen, seen here. So a parasagittal view at the level of the opposite foramen. We'll zoom in on that. And here we have the opposite foramen from the side of the disc herniation. The first thing that I do is I measure the distance from the back of the intervertebral disc to the ventral surface of the superior articular process. And I'd like that dimension to be greater than 4 millimeters. And then the distance from the top of the L5 pedicle in this situation to the bottom of the L4 pedicle in this situation, we want that to be greater than 10 millimeters. The reason for selecting these dimensions is as follows. You're going to insert a cannula measuring 7 millimeters in diameter that's cut on an oblique angle at the tip. We want the tip of that cannula to get to the mid-pedicular line for the majority of interforaminal or far lateral disc herniations. So we're going to insert that cannula about 50% of its diameter into the foramen as diagrammed here. 50% of 7 millimeters is 3.5, which is why that measurement from the dorsal aspect of the annulus to the ventral aspect of the superior articular process is 4 millimeters. The second dimension that we need to take into consideration is this up to down dimension of 10 millimeters. Here we're going to insert the entire width of the cannula in that dimension, so we need at least 3 or 4 millimeters of space available for the nerve root so that we're not squashing the nerve root up against the superior pedicle. If you have this picture in mind of a cannula inserted approximately 50% of its diameter into the foramen with a deep tang of the cannula at the mid-pedicular line, what you'll notice is that you have 12.5 millimeters of cannula opening through which you can resect an intraforaminal or far lateral disc herniation, which is usually sufficient. This measurement works for those situations in which you're not planning on doing any bony removal, you're not targeting a posterolateral or a central disc herniation, and your goal is a relatively straightforward interlaminar or far lateral disc herniation relatively early in your career. Thank you for your time and attention.